Hi. So today I'm going to be giving you a talk on clinical data science. And there are very different names out there for this right now. And some people call it healthcare analytics, clinical analytics. I like the term clinical data science because I feel like, kind of gives you a broad breadth of what is possible. And so today we're going to be talking about the different kind of healthcare data. I'm going to walk through an algorithm example with you, and then we're going to end the talk talking today about some predictive analytics and what is that. And that'll go a little bit more towards the traditional data science route. So I'll give you a brief introduction about me. How on earth does a surgeon become a physician data scientist? And I had a very kind of roundabout way of doing this. This wasn't actually the plan. I went to medical school traditionally, then completed general surgery residency, and was off to be a traditional practicing surgeon when I had two injuries to critical nerves in my arms requiring some surgery. And after I recovered, it was very hard for me to operate the way I had been. So I had some time to think about, well, what else am I going to be doing? And at that time, EMR adoption was huge. Tech was huge. It was starting to emerge. And I said, well, maybe this is going to be, maybe if I go back for tech, I could do healthcare tech. So that's what I did. I went back to school. I learned computer programming, took classes on databases, and off to the races I've been. And I love my career now and would highly encourage anybody who wants to kind of marry those two skill sets to please go ahead, because there's definitely a need. So I'm going to begin this talk talking about the patient-provider ecosystem. What I mean by that is when you're going to the doctor and you have what you think is just a simple office visit, that is not actually the case. There is an entire ecosystem of huge amounts of data that's being exchanged during this visit that you probably don't realize. And this is anywhere from claims data to all the data that's recorded in your electronic health record, to all the clinical data, your blood pressure values, your vitals. All these things are all taken into account. Every single time you go to a pharmacy, you go to a lab, you go for a test, there is a piece of data, or several pieces of data actually, that are exchanged during that time. So we use all these pieces of data, right? I mean, and there's a world of it. There's claims data that I've mentioned. There's data from the electronic health record. There's hospital data. And I'll go into that a little bit, but it's about really hospital performance. There's specialty data, like cancer registry data that's really nice. And then, of course, there's patient data, and that's the data that everybody is now talking about. That's what, all the Facebooks and Instagrams and TikToks, that's what they all kind of leverage, is all of your data. So there's tons of data out there, a huge variety, and I'm going to go into a little bit more depth here in a second. So claims data. Not everybody works with claims data, but there's a lot of advantages to working with claims data. It is structured data. It is pretty much standardized. There's only two types of claims that can be submitted when you go to the doctor, when you're at the hospital, when you have a test done. There's claims that are submitted from the hospital called a facility claim, and there's claims that are submitted by professionals, and that's called a professional claim. And what's in a claim, right? What is this data that's in here that I keep talking about? Well, there is a system called the ICD-10 Diagnosis Classification System. And it is a collection of over 70,000 different diagnosis codes These all correlate to the different diagnosis that a doctor says he assesses you to have. So for example, if you have a meniscal tear in your knee and you go for an MRI, the diagnosis code that's going to correlate to that claim for the MRI is going to be for a meniscal tear. And it's going to be even way more detailed than that. It's going to be, is it a left knee? Is it a medial or lateral? I mean, it gets very granular. There's also a great coding system on these claims that correspond to procedures. There's a huge coding system for procedures, and it describes all kinds of operations, all kinds of radiology tests, all the laboratory tests you can imagine. I mean, it's just very, very comprehensive, and it encompasses the most minor operation to like just a skin biopsy, all the way to the most major heart transplants and describing all of those things. So the procedure codes is a great piece of data that you can get. There's also other things on claims data that if your database is set up right, you can access. This is dates of service. Was it the primary reason for the visit? Where was the service given? Was it in an ER? Was it in a rural health clinic? Those are called place of service codes. And these kinds of claims data are stored in these massive, massive databases because they're all standardized, it's all structured, and it can be, you can design programs for things at a huge, huge scale with big data. What are the drawbacks though? The drawbacks are that it's limited by lack of detail. There's no way that you can tell on a claim and from the data from the claim how many days somebody was on a ventilator if they suffered COVID infection. So there are limitations to claims data, and it is definitely the lack of detail of the clinical picture. Electronic health record data. Everybody is, I think, pretty familiar with this, but if you're not, I'll tell you that, everybody has their own electronic health record. It's got all the kinds of details of your medications and all your clinic visits and all the different reports. If you had a radiology report for a CAT scan, for example, or you had a biopsy, the pathology report's going to be in there. There's all kinds of great detail in the electronic health record data. It is structured and it is also unstructured data. So when I say that, the structured data is going to be things like there are going to be medications, there are going to be the past medical and surgical history is going to be kept in there. But the unstructured data is really in the free text of these notes and reports. And that really encompasses its own methodology and how to capture that data. And that is not going to be part of the discussion today because I feel that unstructured data really deserves its own talk. It's got its own methodologies and really can have its own place in the world. So we're not going to talk about that today. We're going to talk mainly about structured data. The thing about electronic health record data, albeit that it's very detailed and wonderful, is that there's huge variability. There's different EMR systems, different health systems don't really exchange data, or they can, but it's really not uniform. So it's not kept all in one huge database that you can write one program for and run it all through. You've got to kind of work at smaller scale. But there is now a movement to really start to leverage this data a lot more. So despite this smaller scale issue, there are now proposed rules like from CMS that's going to start promoting interoperability. So these kinds of obstacles, I think you're going to see really start to be addressed in the next decade. Hospital data. So hospital data is data about really hospital performance, as I mentioned. And they really tend to be kind of in these categories that are on the slide. Their readmission rates, their mortality rates, whether they're a high volume center for certain things like a high volume bariatric center, or infection rates. And maybe people don't realize this, but the hospitals do submit their infection rate data to the CDC on a periodic basis. So the data is exchanged by hospitals. So that's a wonderful thing. So what if you want data that's really specialized and you really want to work on a larger scale with pretty specialized data? A cancer registry is a wonderful example of how you can design some algorithms that are used specifically for these registries. And the nice thing about this is that it's really filtered data. It has all kinds of things like the different types of cancer, the different stages that the patients might have in the cancer. And it has treatments and survival rates, and it's got great longitudinal data. The downside to registry data, though, is that it's really not updated very frequently. So you have the issue at times of the data not being really current. And last, we're going to talk about patient data. Patient data, it's starting to really just explode, and it's been doing this for some time. Different industries are really ahead of the game, marketing and financial industries with using patient data. But we're starting to kind of, emerge in this field as well. We've got digital health apps. We're texting. There's all kinds of texting data with our providers now. There's satisfaction surveys that are done electronically through our phones. And of course, there's all the data that's captured out in various markets that we have that are kept basically on our phones. So I want to put this all into context. We have all these different pieces of data: claims data, electronic health record data. We've got, and I didn't talk about this on the claims, but we've got some pharmacy data, and we've got laboratory data. And how does this all fit with the bedside? Are we really capturing everything that's happening when you go to see the doctor? Well, of course, the answer is we don't capture absolutely everything. As you'll see on this slide, physical exam, well, how can you capture the physical exam in a database? Well, you really can't. But as you can see by this slide, when you go to see a doctor, they perform a history and physical. And you'll see here that the different pieces of the history and physical that the doctor performs, there's data that kind of fills in all of those spots. You've got your history of present illness, which is what the doctor does when they say, what brought you here today? You tell them your primary concern, and they start to ask these kind of, classic questions. Well, we can design algorithms that ask patients, are you having shortness of breath when you lie down? That's a yes or no question. Or have you had a fever? That's a yes or no question. So we can kind of chip away at that first part of the visit if we sort of know really why you're wanting to see the doctor. Then there's other things, past medical history. Again, that's where the diagnosis code system really plays a big role. Past surgical history, again, the procedure codes, the CPT codes are a huge deal. Now you have your medications, that's in an EHR, claims data. And then you've got all these other pieces, right? The labs, where you have claims, or you can get it in the EHR. And then there's pockets of information like imaging that really you can only obtain using EHR data. But at the end of it all, the doctor comes up with their assessment, and part of that data is captured on the claim, as well as the EHR. What diagnosis did they think you had? What diagnosis did they bill for? That's on the claim, and that's in their assessment in the note. As well as the plan. What are they going to do? Are they going to prescribe a medication? Are they going to order a test? All those things are sort of, again, there's sort of a claim paper trail, and it's documented in the EHR, hopefully. We're going to talk a little bit about predictive analytics later, so I'm going to just kind of ask you to make a mental note of that. But before we move on from this, I want you guys to take away 4 pieces of data that we're going to use to design an algorithm for patient care. We're going to use the diagnosis codes. We're going to use the procedure codes. We're going to use the pharmacy information, and we're going to use laboratory information. And you'd be amazed at how many different combinations of algorithms you can design with those 4 pieces of data. So we're going to now walk through an algorithm example, and I'm going to kind of show you at a high level the process that is generally used for simple algorithms. So a real world example is we're looking at all the patients with diabetes who have coronary artery disease, and we want to make sure that they are on an appropriate drug that has been shown to help diabetic patients with this also additional diagnosis problem of coronary artery disease. So we're going to take an algorithm, and it's going to basically fit the bill of this sentence. We're going to get all patients who were admitted with new cardiac disease, who had a cardiac catheterization during their hospital stay, who also have a past medical history of type 2 diabetes, who are not on Jardiance. And Jardiance is a drug that has been shown to improve outcomes in these type of patients. So we're going to, remember what I said, we're going to use the diagnosis codes system to design our algorithm. That's one component. So we're now ready to use the diagnosis codes. We're going to define new onset cardiac disease requiring hospitalization with claims data. So we're going to go through all those 70,000 diagnosis codes, and we're going to pick the codes that correlate with cardiac disease. Now, you'll see here in bold on the left slide, ICD-10, code I25.10, and the family of codes that go along with that, they describe cardiac disease. So we're going to pull and extract all the patients that meet that criteria. But we're not done, because we're looking for new cardiac disease and somebody that was hospitalized for cardiac disease. So we're going to say with the criteria of the algorithm, oh, that patient also has to have a hospital claim where the cardiac disease code was the main problem for the hospitalization. So it's not just all patients who have cardiac disease. It's only patients with that hospital claim that have that diagnosis code on there that are going to be now included into the algorithm. And of course, we're not done, because we have the new cardiac disease, the new component of this. So how are we going to establish new disease? Well, we're going to basically say, we're going to use that diagnosis code, look at that hospitalization, and say, anybody who had that diagnosis code prior to the hospitalization is not included in the new cardiac disease. So we will take that cohort of patients and remove them. And so we are basically doing this programmatically, saying, now you are only getting patients with cardiac disease. You are only getting the ones that have a hospital facility claim where cardiac disease was the primary problem. And we're removing all the patients who have had a prior code for cardiac disease in the past. But of course, that's just the first piece of the algorithm. Once you're done there, you're going to repeat that whole process. But remember, we have 4 pieces of data. We have the diagnosis code, the procedure code, pharmacy information, and laboratory information. So now we're going to use the procedure codes, because we're going to look for people who have a cardiac catheterization. So remember I told you there's all these codes that describe different procedures. We're going to go catch those procedure codes that are for a cardiac catheterization, and we are going to now plug that into the algorithm as that is a defining codes for cardiac catheterization. So the top of the algorithm says pull all the people with new onset cardiac disease. Then the next part of the algorithm says of those people, pull only the ones that had a cardiac catheterization. Next, we're going to repeat the process. We're going to say, we're looking for type 2 diabetes. How can we define that? Type 2 diabetes is a diagnosis. So obviously, we're going to go back to the diagnosis code system, pull all the codes for type 2 diabetes, all the ICD-10 codes, and we're going to plug that then into the algorithm. So we've got 3 pieces of the algorithm that are all going to be together because these are all criteria that we're looking for. But you can see by my methodology that you take them kind of piece by piece. You establish a definition for one criteria, second, and the third criteria. So at the end of all that, we're looking for the patients who meet all this criteria, who do not have a pharmacy claim for Jardiance. So we look, the program says, does the patient have a pharmacy claim for Jardiance? If the answer is yes, we're excluding them, and we're only left with the patients who do not have that pharmacy claim, who did not go to the pharmacy to fill this drug with a pharmacy claim in place 2 months after the hospitalization. Well, this is where having a physician help design these is critical, because there's a flaw in that algorithm. It is basically implying that all those patients should be taking Jardiance, and that is simply not the case. There is a contraindication to the drug where people with advanced chronic kidney disease should not be on this medicine. So we're going to go back and I'm going to show you how to refine that algorithm with that clinical knowledge. So again, when we go to design an algorithm, you begin with defining the condition, the procedure, the pharmacy or the lab. In this case, we're doing the diagnosis. We're going to define chronic kidney disease. We're going to, again, use the ICD-10 codes that correlate with chronic kidney disease. So, but, if you do this, you can say, well, I really want to give the physician the benefit of the doubt. How else can I do this in this algorithm design? Well, you can say, let's find anybody who also has a laboratory value that is indicative of kidney disease. So you look for anyone with a lab value of a creatinine level greater than 2.0, either on a laboratory claim. If you're mixing the data, you can do EHR data. But really the cleanest kind of example here is all using claims data. And you can get all of this on claims data. So where would we insert this block of code, right? We just did a block of code. Well, sometimes it matters, sometimes it doesn't. In this case, it really doesn't. We're just going to put the whole exclusion of the chronic kidney disease at the very end, right before we look for the pharmacy claim. We're going to add that block of code for chronic kidney disease into the end of this algorithm prior to looking for that pharmacy claim. And anybody who meets the criteria of chronic kidney disease is now excluded, programmatically excluded from the algorithm. And at the very end, you have people who have cardiac disease, who had a catheterization, who have type 2 diabetes, and do not have a kidney problem. Now we're looking for the pharmacy claim. Now we've hopefully found the right type of people that can benefit. So for the interest of time, I'm going to just move forward. How are these algorithms used? Well, care gaps, identifying care gaps in patient populations where quality of care could be improved. This is an example of what we just walked through. You can use these algorithms to look for cost-saving opportunities in healthcare. That's also a very popular use. And then you can just use them to evaluate quality of care in physician practices or hospitals. Well, where do these algorithms come from? Do people just create them out of thin air? Well, you can create what I call de novo algorithms, but generally speaking, when they're used in mass scale to really look at quality of care, you go to some national consortiums where they're designing these criteria that are really vetted by a very large board of doctors. And there's a consensus that that is actually the best standard of care. So 4 examples of this are the National Committee for Quality Assurance, and this is basically your HEDIS measures. They've got great kind of metrics for looking at colorectal screening, breast cancer screening. They have a comprehensive diabetes care collection of metrics. The next one is Agency for Healthcare Research and Quality. And this has kind of its own flavor. I would say that it's a little bit more like population health, but it's got some great things. I've implemented an algorithm looking at C-section rates in hospitals. So that's one example. National Quality Forum is a great place to extract new metrics or measures. They've got all kinds of different measures on different specialties that NQF endorses. And of course, there's CMS. And CMS, most people are familiar with, and they design different criteria, quality of care metrics all the time, kind of almost continuously. So when we're thinking about data, as I've shown you before, these metrics can be used either with only claim, only EHR, or it can be used with what's called a hybrid metric, where it uses both. That's really the ideal situation, but it's tricky. It's tricky. Your database has to be designed in a way that you can piecemeal that. And this is sort of where everybody is sort of going for the future. So now I'm going to switch gears. We're going to talk about predictive analytics. We're going to go back to that slide of the history and physical, and we're going to talk about where predictive analytics can kind of play a role. It can play a really big role in the plan of care. It can help recommend, based on all the patient data, what the next sort of mode of treatment will be. There are some algorithms that I've helped design that kind of are more in the past medical history, past surgical history side of the history and physical kind of place in the examination. Who's at higher risk for conditions, who's at risk for surgery. Those are other examples of things that predictive analytics can play a role in. So this is just an example of predictive analytics. I don't think anybody really thinks about this who's not a data scientist, but all these apps and everything that we're interacting with right now, they're all sort of predicting what you're going to want to do next. I listen to jazz music in the morning. So YouTube says, oh, we know this is an easy prediction for us. Let me pull up all the jazz music that, she tends to listen to from the different venues, and they kind of repeat. And we might not be really thinking about, this is what this is doing. It's predicting what I would like. On Facebook, they're predicting what you might like based on your data, based on your history. Well, when we're thinking about healthcare, imagine if we could take all that patient data, not only claims, not only EHR, but even some of our extra data that every place else is using right now, and start developing, a narrative of what a patient is at risk for, what is the potential of care, what is the potential plan of care, So it's a huge growing field in a huge area of potential. When I talk about predictive analytics, I want to get a little bit more specific because there's 2 sort of major bins, and one is regression models. These are used kind of to predict values or to predict outcomes. One example is, what is the likelihood of having a pulmonary embolism if you have a DVT? This is a logistic regression model that I have helped design in the past. And it really kind of uses all the different pieces of data. You insert it into the regression model, and the regression model kind of tells you whether the patient is predicted to have it or whether it's not, or whether they're not. The next major category is artificial intelligence and machine learning. These are really great. They help predict conditions. They, a couple of different projects I've worked on that I'm giving you examples of. They can predict people who have had an adverse drug reaction, who's predicted to require back surgery if they have back pain. So, you've got these two bins. Well, what are the downsides to each of them, or, what's a little bit more about them? I'm going to spare y'all any formulas or any of that today. That's, I think, for a different day. So I'm just going to kind of try to put this in high level terms for everyone. The regression models really are taking a designated set of variables with different weights in very established models. We've had regression models around for a really long time. So we know kind of what they do. They provide a predicted value and likelihood of event occurring. And with that value, you can kind of compare what your actual result was to the predicted. And you can see, well, am I performing better or worse than what a model predicted for my readmission? Well, there are different factors in going into what puts a patient at risk for readmission, and a couple of different variables that you might want to focus on, or a model might focus on, is things where, does a patient have heart failure? Does a patient have really bad coronary artery disease? So those kinds of models will take that into account. Machine learning models also take variables into account, but it really is a lot more variable. I hate to use that word twice. There's not uniformity in how these models are designed. Different designers use different variables, and there's not a whole lot of, established models per se, the way regression models have. So it is a mixed bag. It really depends on the designer. I have been an active participant in a lot of these model designs as the clinical kind of point of contact for them. A couple of examples would be hyperkalemia, hyponatremia, who are at risk for that when they're taking a drug. And what I had to do was I had to extract my clinical knowledge. And this is why, again, I'm going to say it's really important for physicians to be an active part in this process, because I had to take my clinical knowledge. Well, what do I know about hyperkalemia? Who's at risk for hyperkalemia already, even without taking a drug? Advanced chronic kidney disease patients, people on certain drugs. Same thing with hyponatremia, low sodium value. What do I know from my medical knowledge? Again, that puts you at risk for that. And these are things that were inserted into some of these models to help kind of build the model and use for different variables. But again, it wasn't something that I had an established design for. We design these. And so you'll hear people talk about bias. And it is a very, very legitimate complaint about these, in that there is bias. There is bias by the designers, and that is something that I think is really up for discussion, especially, with some of the things that are just coming to light from some of these algorithms. So issues, I know I touched on this. Some issues with machine learning models. A lot of these are proprietary. You'll hear black boxes. They are not open openly published on how they're designed. We just kind of have to take their output. So, you know, this is not like a research paper where, you know, and you have some people now publishing their work on machine learning model design. But generally speaking, if they're used out in industry, these are considered proprietary. And at times it's really difficult to determine why some people were predicted when it makes no sense. So some of this is just a false positive. And tackling that issue is something very real and something that we've had to deal with, because you don't want to be identifying wrong people and reaching out to doctors, or, you know, having care interventions with members when the model is wrong. And the last issue, I think, which is really a huge issue, is we're just not having enough interaction with the end user, the physician. We're not putting this model output out to the doctor who's at the bedside with all the patient information and, you know, maybe years of established relationship with this patient, and seeing whether this person was really accurately predicted to have a condition or not based on all their knowledge. And this can really help us to ensure that we're capturing accurate data in our model design. So what will it take to move forward? Again, we have to have a lot more input from physicians and patients, but really physicians need to be part of the model design. And we need to not forget about the patient. We need to make sure that we are designing these algorithms in a way that they are used only for the way that they were designed. If you use an algorithm that is designed really just to help a physician, and you take it out of context and start using it for patients in a way that, you know, wasn't designed for, patients have a whole different perspective on what's important for quality of care. And you will have to design those a little bit different than you will one that is used solely to help a doctor at the bedside. So you really, you know, you need to sort of stay strict to how these are designed. Another thing is, on the whole other end of the spectrum, we have to have some tolerance for error. We should have safety guards in place. Our doctors are, of course, our safety guards, but we, you know, have to understand that these things need to be trained. When it's early on in model design, sometimes, you know, you need to go back and you tweak it. Oftentimes you need to go back and tweak it. These things need to be trained. Something that you learn brand new, once you're doing it, you know, for the first few times, you're nowhere near as good as when you've done it, you know, for years and years and years. These models are no different. They need to be trained and reiterated over and over to find areas for improvement. And my last slide is about the different loop. So basically, you know, what this is this just shows you sort of the feedback loop that needs to be in place, where we design the AI model, hand it over to the physician at the bedside. The physician give us feedback on whether that model was accurate or not, and document why. Then the model designers need to go back, readjust that model based on the feedback, give it back to the physician. And that's why I'm saying there needs to be a tolerance for error here. And there definitely needs to be more doctors who are involved here. So thank you so much for your time today, and I hope that I have taught you something new that you can walk away with.